This is the case of Zack. Zack is a 6-year-old mixed-breed male castrate canine that presented with acute onset of neck pain and significant left front limb paresis. On physical exam, Zack demonstrated extreme neck pain during manipulation in any direction and had a severe left front limb lameness. Based on these findings, we were suspect of an intervertebral disc protrusion or extrusion that localized somewhere between C2 and T1. We were also suspect of a lesion that could be causing a root signature of the left front limb. Our initial diagnostic plan was to obtain plain films of the cervical spine, followed by a myelogram and possibly a CT exam. This is a lateral view of the cervical spine of Zack. Note that an endotracheal tube is present, indicating Zack is under general anesthesia. For the most part, general anesthesia is required to obtain diagnostic quality plain films of the cervical spine. There is moderate narrowing of the C2-3 intervertebral disc space as well as several disc spaces in the mid-cervical region. Caution must be used when evaluating cervical spines, however, in that the mid portion of the cervical spine tends to swoop down due to the effects of gravity. This can only be prevented by either stretching the spine or by placing a radiolucent wedge underneath the cervical spine to help raise it up. If this is not done, the narrowing of the intervertebral disc spaces will mimic sites of possible intervertebral disc extrusion. Also note that the wings of C1 are perfectly superimposed and the wings of C6 are also perfectly superimposed, indicating that we have very good straight positioning. If you look closely, there appears to be mineralized disc material centered over and dorsal to the C2-3 intervertebral disc space. We will see this again later on a close-up view. On this VD view, there is slight rotation of the cervical spine, and the endotracheal tube hinders evaluation. Oftentimes, the VD views of the cervical region are not as helpful as the lateral views when looking for intervertebral disc disease. This is the close-up view centered over the C2-3 intervertebral disc space. Note that there appears to be mineralized disc material both in the intervertebral disc space at C2-3 as well as dorsal to and centered over the intervertebral disc space. A myelogram was then performed using Omnipaque or iohexol, which was placed into the subarachnoid space. This provides contrast around the spinal cord, making evaluation for evidence of intervertebral disc protrusions or extrusions, otherwise known as extradural compressive lesions, much easier to find. There is thinning and narrowing of the contrast column centered over the area of mineralized disc material at C2-3. Again, a close-up view of this will be shown shortly. Like the plain film, the VD view of the cervical spine was not very helpful in this particular case. This is a close-up view in lateral projection of the cranial aspect of the cervical spine. Again, note that there is splitting of the contrast column as well as thinning of the column where it deviates over the suspect extruded intervertebral disc material at C2-3. That is indicated here by the red arrows. There also appears to be a small amount of mineralized disc material at C3-4, however, no deviation of the ventral or dorsal contrast column is seen at this site. This is again a lateral view showing the mid to caudal portions of the cervical spine after a myelogram. At first glance, there does not appear to be any deviation of the ventral contrast column at any of the intervertebral disc spaces. Careful evaluation, however, shows that there is mild splitting of the contrast column on the ventral aspect seen at the C4-5 intervertebral disc space. Actually, the splitting starts just cranial to this region, here seen by the red arrows, and extends just caudal to the C4-5 disc space as well. Note the prominent normal lateral spinous processes of C6 compared to the remainder of the cervical vertebrae. Because these spinous processes are different and prominent, C6 is often used as a landmark. So our diagnosis so far is that we have a defined extradural compressive lesion at C2-3. However, we can't localize the side. In other words, I can't tell if this lesion is right-sided, to the left, or midline. No other definitive lesions are seen. However, we are suspect that there may be another lesion, possibly at C4-5. So our plan is, do we do surgery at this point? Are we ready to do surgery? Do we need to do additional diagnostics? Do the radiographic findings perfectly match the history and neurologic exam findings? Or do we need to do a CT examination to further explore the other possible lesion at C4-5 as well as help localize the site and side of the lesion at C2-3? We did a myelogram, and this is a video of the C2-3 intervertebral disc space. Note that there is significant amounts of mineralized disc material that has extruded from the C2-3 intervertebral disc space, causing compression of the spinal cord. It is obvious that this lesion extrudes dorsally as well as slightly to the left of midline. This is a transverse static image on the right side at C2-3, showing the large amount of mineralized disc material that has extruded, here shown in pink, as well as the green shaded spinal cord that is compressed secondary to the extruded disc material. The image on the right is a sagittally reconstructed image, again showing the large amount of extruded disc material, here seen in pink, that is causing significant dorsal deviation and compression of the spinal cord seen above it. So again, back to our plan with Zack. Are we ready to do surgery, or do we need to do additional slices with the CT of the C4-5 intervertebral disc spaces or any other spaces? Again, we have to ask the question, do the diagnostic findings completely explain the clinical signs, history, and neurologic exam findings? And of course, in this case, no, they don't. A root signature, as Zack has of the left front limb, is usually caused by a lesion seen in the mid to caudal cervical region, usually between C4-5 and C7-T1. This brings up an important point. If during the CT examination, if the radiologist or neurologist were not available at the time of the CT to make this decision could not be made, or a lesion will be missed. In Zack's case, a slice through all of the remainder of the intervertebral disc spaces in the cervical region were obtained. The image on the left shows a slice centered over the C3-4 intervertebral disc space, on the right at C4-5. Note that in both of these cases, we can see contrast material within the spinal canal surrounding the spinal cord. The image on the right is at C5-6, and the image on the left is at C6-7. Are all of these slices normal? Do we see any evidence of any other suspicious sites? Well, obviously, yes, we do. We see another suspicious site at C4-5, possibly on the left side. Again, if the radiologist or neurologist were not actually present at the time of the examination, this decision would be very difficult to make. And again, lesions may be missed. This is a close-up view of the slice taken at C4-5. Note that there appears to be dorsal deviation of the spinal cord and contrast column on the left side centered over the C4-5 disc space. Also note that the lateral foramen at C4-5 on the left side is wider than that seen on the right side. This is a video of several slices taken centered over the C4-5 disc space. A close-up view showing the C4-5 disc space shows that there is a large amount of disc material that is mineralized that is causing dorsal deviation of the spinal cord. Also note that a large amount of disc material is seen extending into the lateral foramen where the nerve root exits on the left side at C4-5. So in Zack's particular case, Zack has two lesions. He has a significant extradural compressive lesion caused by extruded disc material at C2-3 that goes dorsally and to the left of midline. He also has a significant lesion at C4-5 that lateralizes to the left of midline and extends out laterally into the foramen. So now we can explain all of our neurologic findings and clinical signs, even the root signature. Our plan is now valid and we can do a ventral slot decompression at C2-3 and C4-5, which indeed was performed for Zack. Large amounts of disc material were removed from both of these sites. Zack made an uneventful recovery and eventually walked out of the clinic and did extremely well.